Hello everyone. So in this video we are going to talk about a very high yield USMLE concept. It's going to be important for particularly USMLE step 2 CK and 3. We are going to discuss the algorithm for the management of pulmonary embolism. So most of the next best step questions this algorithm is going to answer. Very high yield. So pulmonary embolism. So the first thing you need to know is what could be the features of pulmonary embolism. What can they give in the question? So there is a scoring system called Wells criteria. So just listen to which symptoms that are signs the question is going to tell you, and then you can find them in the Wells score, and then because you have to calculate the Wells score, and based on that you are going to do the management. So some of the features include, for example, signs, for example, sinus tachycardia. So tachycardia, you can also have, very rarely you may have hemoptysis. Usually there can be a history of some procoagulant state where there is increased risk of thrombus formation, for example DVT. For example, the patient has malignancy, which is increases risk. The patient is immobilized or prolonged flight, cannot is unable to walk, wheelchair bound, for example. So or cannot move, is seated for a prolonged period of time. So those are the patients at risk. So these are some of the risks that you are going to look for. And then the signs include chest pain, sinus tachycardia, tachypnea. Tachypnea they can give on ABGs as PCO2 is going to be decreased, pH is going to be increased, so that's respiratory alkalosis. HCO3 usually is going to be normal. So now let's talk about what Wells score criteria is. So you need to know the features for in the modified Wells score. So these are the features. 3 points are given for if you have DVT signs. Remember, in the question they will almost never give you DVT signs because that makes pulmonary embolism diagnosis very easy. Second, 3 points are also given if the alternate diagnosis is less likely. So if you cannot think of anything else, then that's also given at 3 points. If you think that apart from pulmonary embolism, I don't think that there is anything else going on with the particular patient. Then there are certain other things, and those are given 1.5 points. For example, if someone has previous pulmonary embolism or DVT, that's 1.5. If someone has tachycardia, that is 1.5. Recent surgery, remember, is a big risk factor. Patients are immobilized, or immobilization in general, prolonged flight, wheelchair bound. So these are the patients that are given. Each of these are given 1.5 points. Then malignancy and hemoptysis has 1 point. So remember, you may not be able to remember this Wells criteria, all of the scores. So just keep in mind a general things that are included in the Wells score. And if you can see at least 4 or more of these features, it's almost certainly PE likely. So remember, if you get the Wells score and out of these features you get a score of greater than 4, that means the Wells score is greater than 4. It means the pulmonary embolism is likely. So first step in pulmonary embolism, if you're suspecting someone has it, is to do the Wells score. Now, let's say the Wells score is greater than 4. What is the next step? Well, the next step is it is PE likely. We know that. So what do you do? So let's say the options are CTPA, another option is anticoagulant. The answer is start anticoagulant heparin right away, because CTPA may take time. So you don't want to delay the treatment if the PE is likely. So start anticoagulants. Start anticoagulant heparin. Now, you start anticoagulant at the same time you are going to do CTPA, which is confirmatory. So CT pulmonary angiography is confirmatory. Now, let's say the Wells score is less than or equal to 4. Then that means that PE is unlikely or less likely. So in that case, what is the next step? Well, the next step in that case would be to do a D-dimer test. Now, you did a D-dimer test, and let's say the value that you got is less than 500 nanogram per milliliter. So if you get that, it rules out pulmonary embolism. So you move on and find some other cause. If it is greater than 500 nanogram per deciliter, then that is probably PE now. So what do? Remember here, don't directly start anticoagulant. First, do CTPA. If it confirms it, start anticoagulant. So this is the general algorithm to move for about the questions of pulmonary embolism. Another thing is there are different variations. There are different questions they can give from this algorithm. For example, let's say they say someone has a contraindication in the question to anticoagulants. Well, for example, someone has hemophilia or some bleeding disorder. So what do? Well, then you do IVC filter. You do inferior vena cava filter. So it stops further thrombus from coming from the DVT up to the pulmonary circulation, to the pulmonary trunk. Now, so you need to know that the deep vein thrombus, usually above the knee, is the one that is most commonly is going to cause pulmonary embolism. Below the knee is going to be a bit rare. Now, when to give thrombolytics? So you have to think about it now. Anticoagulants are not the same as thrombolytics. Thrombolytics are a bit different. They actually break down the clot. They bust the clot. While anticoagulants prevent the propagation of the clot. For example, if you have a, let's say, 2 centimeter thrombus, if you give them anticoagulants, it's going to stay like 2 centimeter. It's not going to expand. But if you give thrombolytics, it is going to just kind of break it down in its entirety. So the entire thing is broken down and now you don't have a thrombus. So it's a very powerful anticoagulants, you can say, thrombolytic. So when to give thrombolytic in pulmonary embolism patients? So in the question, if they give you IV right ventricular failure signs or shock in pulmonary embolism, then you can give it. You need to keep in mind that thrombolytics are contraindicated in certain conditions, like if platelet count is less than 100,000, like if you have a recent head injury or recent surgery or intracranial bleed. So all of those conditions, thrombolytics contraindicated. Now, the question may also ask, what is the most common ECG abnormality? So remember, it is sinus tachycardia. Also, the question may ask more specific ECG abnormalities. You have to pay attention to the question and what they are saying. It is S1, Q3, T3. So what is that? So you're going to see in lead V1 S wave, you're going to see Q wave in lead 3 and T in also lead 3. This represents right ventricular strain. So if you think about it, the thrombus is in the pulmonary trunk. The right ventricle has a strain. It has to contract the blood out and overcome that obstruction of the pulmonary embolus. So what happens? Right ventricular strain. And on ECG, it is S1, Q3, T3. Remember, there is something called paradoxical embolism, in which the DVT thrombus actually goes through the ASD, atrial septal defect, to the left side and then causes systemic embolization and bypasses the pulmonary circulation. Right, what is the most common chest X-ray finding they can ask? So the most common chest X-ray is normal. There are some rare features that can be seen on X-ray. For example, you can see Westermarck sign or Hampton hump. In Westermarck, for example, there is wedge-shaped infarct that is seen on X-ray, but these are rare. If they say what is the most common chest X-ray finding, normal. Last thing they may ask is, what if you cannot do CTPA? For example, let's say the patient has renal failure, or the patient has some contrast allergy, cannot do CTPA. What do? VQ scan. Hope this video was helpful, and this is definitely going to get most of the questions about pulmonary embolism right when you're doing your test questions. Hope this video was helpful, and if anyone requires tutoring, they can email me. Link will be in the description. And also, I'm going to put links to some other sites where you can support the channel as well. Thank you for watching, and see you in the next video.